NASTAD's PrEP financing webinar series focuses on strategies to leverage Medicaid, private insurance, and safety net programs to expand access to PrEP across the country. This third session in our series focuses on how programs are evaluating PrEP utilization with a focus on strategies to leverage healthcare systems data. For today's webinar, I'll provide a brief overview of the continuum of PrEP care that I hope will be useful in contextualizing the different processes that we'll describe, and we'll go over some key terms for today's discussion. Our presenters today are Dr. Julie Myers, the HIV Prevention Director at the New York City Department of Health and Mental Hygiene, and from the Utah Department of Health, we have Matthew Meechan and Ahmer Afroz. After their presentations, we'll have quite a bit of time for a discussion with the presenters. Following the deep dive approach that we've been taking throughout the webinar series, we've asked our presenters today to focus their presentations on a couple of examples that show how they have accessed and analyzed health systems data and how their findings from this analysis is being put into action. Our learning objectives for the webinar are to identify key opportunities to leverage health systems data sources for PrEP evaluation, describe the uses of these data sources, including increased capacity to measure progress on PrEP uptake and retention indicators, as well as participant characteristics, and understand the process that peer health departments have followed to conduct these analyses. Although today's webinar is focusing on health systems data, I want to frame our discussion in the context of the PrEP continuum of care, and specifically the purpose of leveraging health systems data and how they fit into our overall PrEP evaluation strategy. At our last webinar, Tim Horn described the primary HIV prevention cycle, a framework that TAG and AMFAR have been working on. And in his presentation, Tim proposed a cycle that emphasizes the importance of assessing the needs of the client on an ongoing basis, and based on those needs, pursue linkage and engagement strategies. We've also talked about the additional process indicators that help us understand the gaps between the bars, and through that understanding, prioritize and strategize support services and other activities needed to decrease health outcome gaps and effectively respond to social determinants of health. We know not everyone is at the same risk for HIV infection, and having a framework that reflects the need for targeted services and at the same time includes large-scale strategies for individuals at lower risk is going to be important. Our conversation today focuses on some of the opportunities that these data sources have provided for health departments, including the ability to estimate population-level PrEP utilization, track disparities in access to PrEP across provider and payer systems, and socio-demographic breakdowns. In addition, when matching these data to HIV and STD surveillance systems, they have enabled HIV programs to monitor engagement into PrEP. They've served as a proxy for adherence. They've been able to validate their PrEP user estimates and algorithm used, identify PrEP uptake and retention correlations with socioeconomic, demographic, and syndemic factors in a way that deepen their outcome monitoring capacity. Engaging third-party payers has been another key component of this. Evaluation of this kind is critical in engaging funders and third-party payers in supporting PrEP initiatives. In addition to forecasting models currently available, a short-term return on investment analysis and a syndemic approach to the impact of PrEP and comparative cost-effectiveness models are going to be key in enlisting the support of state legislatures and third-party payers. And of course, in public health, we are well aware of how important these types of analyses and evaluations are for resource allocation and how powerful of a tool they can be for this purpose in public health. Evaluation can be particularly challenging for health departments given its reliance on data from health systems, but these data are key to gaining a full understanding of the landscape in a particular state. Data from the 2014 National HIV Behavioral Surveillance System, which surveyed MSM in 20 cities with high HIV prevalence, shows that over 3/4 of HIV-negative, sexually active MSM who were considered candidates for PrEP under CDC's guideline had current insurance. This would mean that services needed for PrEP would be available to them through the healthcare system, and in order to be able to capture them in our understanding of a jurisdiction-wide PrEP picture, or landscape, we would need to be able to pull data from these systems to be able to capture a full picture. Health systems data include clinical procedure and diagnosis claims data, pharmacy transactions on the payer side. And on the provider side, they include electronic health records and patient registries. These are some examples of the indicators that health departments can use from each data source. And in the middle, you can see that there is an overlap in the data points that are available through both sets of data. A couple of HIV programs have been able to use a combination of prescription drug and diagnosis codes to track PrEP utilization, for example, being able to capture some of the demographic breakdowns and patterns of utilization by geography and over time and through other key characteristics. You can see here an example of claims data in action that Gilead presented at a recent conference a couple of weeks ago. In this example, they're using claims data to be able to estimate their national PrEP uptake. And they were able to track the number of individuals initiating PrEP over time. Through this analysis, you're able to see the growing disparities by race and ethnicity between 2012 and 2015. This information was leveraged through the pharmacy claims data that we're able to pull. As part of our conversation today, it's also important for us to understand the limitations of these sources of data. These data sources have a lot of holes in capturing individuals' risk for HIV infection, the way that behavioral surveillance has been able to do. Another limitation might be how race and other demographics have been captured. So for this example, Stacy Bush at Gilead had to use a subsample because not everyone had reported race and ethnicity and could be used for this particular analysis of the trends. The other piece to mention in terms of a limitation is that prescriptions filled, which is the specific query used on this uptake estimate, is a very good proxy for retention and adherence as well as uptake, but it's not 100% accurate. Keeping in mind that we're using a data source that was originally not necessarily intended for this kind of surveillance is important for us to keep in mind. And then the other challenge is the lack of a dedicated ICD code. And our presenters today will show you how they have been able to get around some of those challenges. This requires PrEP analysts to conduct a multi-step process to identify individuals accessing Truvada for PrEP. NASTAD just released a billing and coding guide for HIV prevention, which is a good introduction to the codes related to PrEP. Accessing health systems data, including information on prescriptions filled across payers and providers, continues to be a challenge for health departments to be able to evaluate PrEP uptake locally and nationally. And many HIV programs have been able to establish data sharing agreements with healthcare payers and authorities, but many challenges still remain. Health departments have acquired health systems data through bilateral data sharing agreements with their state Medicaid office or through health information exchanges. Private vendors such as IMS Health have also been used to acquire and analyze these data, but the cost of using these vendors can be prohibitive. State and local health departments across the country are at very different stages also in terms of their overall evaluation process. And so to prepare and analyze these vast data sets, some health departments have relied on internal capacity, but many have also contracted with universities and health informatics experts. The Research Data Assistance Center at the University of Minnesota specializes in providing TA on Medicaid claims data in particular. In terms of the analysis opportunities, we discussed estimates for PrEP uptake, the tracking of retention and adherence, the identification of and response to disparities, formulating cost analyses that compare different models, and of course, engaging payers in paying and supporting interventions related to PrEP. So I hope this has been useful. I'm going to turn it over for her presentation and to share the amazing work that they've been doing at the Department of Health in New York City.
With my talk today, first I'll be speaking about the PrEP landscape in New York City and kind of the various data sources available to us. And then I'll be going more in depth into a description of how we've used Medicaid data, both our colleagues at the state and then how we're planning to do so in New York City. And finally, I'll tell you about a unique project to leverage electronic medical record data. So this is, before I can even get into any detail about anything, I just wanted to orient you to PrEP programs in New York City. So this is a schematic that shows our prevention continuum. And now I'm going to superimpose onto it the variety of activities that we are conducting to support PrEP implementation in New York City. So you can see we have the yellow bar are activities that we've always been doing in HIV prevention, condom distribution, behavioral interventions. But then the orange set of boxes are activities to support having possible PrEP consumers even just become aware of PrEP and helping them to link to prevention services. Then in pink, there are some boxes that describe activities that we're doing to engage with providers. And then finally, on the bottom of the screen, I'm showing you some planned programs that will ultimately really, in some cases, span the whole continuum to help improve access to PrEP for priority populations. And as well, we're planning to implement PrEP in our STD clinics. I could spend another 10 minutes orienting you to this slide, but I think the concept here is that we have a lot of different activities that are all intended to be supporting getting patients from kind of A to Z. So those at epidemiologic risk and taking them through a prevention continuum to ultimately beginning PrEP. So in terms of what and how to measure it, we wanted to be able to measure the impact of all of these programs across the jurisdiction. So we started with an activity to really map all of our data sources, which is what I'll walk you through now. So first we had to define our key outcomes, and we really felt like, at the most basic level, we were interested in PrEP awareness and use. So those really became the primary outcomes. But then in terms of secondary outcomes, there's so many, but we've been focusing primarily on the concept of like when someone is on PrEP, what is their adherence? PrEP literacy, which is really more just like, do people understand how well PrEP can work? PrEP stigma, so are people disclosing their PrEP use to possible sexual partners or other people in their lives? And then a variety of others, including like all of the various steps of the prevention continuum I just showed you, making sure that we are able to assess barriers to progressing through the PrEP continuum. So that's the what. In terms of the how, we kind of thought in terms of an approach, I mean, there's so many different ways to really organize our data sources conceptually, but we kind of came across a couple of dichotomies that seemed important to us. Like, are we talking about individual level data versus population level data? Are we talking about data derived from consumers versus data derived from prescribers? Are we looking at cross-sectional data versus longitudinal data? And then similarly with, in terms of data collection, is this surveys where we're kind of collecting the data a priori, or are we using like existing medical record data or administrative data? And then finally, is it surveillance data versus specific program data? So ultimately, the mapping I'll show you today uses two different dichotomies, the consumer prescriber dichotomy and then the surveillance program data dichotomy. So this is kind of what we ended up with when we started beginning our PrEP mapping. It's a 2x2 table of kind of surveillance program up above, and then to the left, provider consumer. And now I'll walk you through the variety of data sources that we ultimately had available to us and how they fit into the mix. And just to be really clear, when I'm talking about surveillance, I'm using this term like quite broadly, not just disease surveillance in the traditional sense, but some of the kind of administrative and electronic medical record systems. To a certain extent, we're considering surveillance data. So now let me walk you through first the surveillance data that are really derived from consumers. And here we list our own sexual health surveillance work, which is really kind of a local version of the National HIV Behavioral Surveillance Project, NHBS, I'm sure is familiar to folks here on the call, as well as the Medical Monitoring Project. Obviously, MMP in general is focused on people living with HIV, but we're interested in their understanding of PrEP and whether any of their partners have access to PrEP. Then moving along to what are the program data sources that are derived from consumers. Our New York City Department of Health and Mental Hygiene Field Services Unit, they're the group that does all of our partner services. So they really have interaction with both people who are newly diagnosed, the index patients, as well as their partners. And to a great extent, we believe that the partners of these individuals are really prime candidates potentially for PrEP. And so we're interested in accessing better understanding their awareness and use of PrEP as well. So that is an important data source. And then moving along to our sexual and behavioral health program data. These are, we fund several different clinical sites to provide sexual and behavioral health, just like the name sounds, services to primarily focus on uninsured and underinsured men who have sex with men and transgender women. So we're using data from those programs as well to follow PrEP implementation across the jurisdiction. Then moving along to surveillance data derived from providers. Again, here is surveillance data in the classic sense in one case, and that we're using our own health department HIV/AIDS surveillance. So these are, obviously these people are newly diagnosed, but we're able to assess whether they were aware of and or accessed PrEP prior to being diagnosed. And we're also using data from our primary care information project, and that's what I'm going to be talking about towards the end of the talk. I just wanted to clarify, backing up for a second, that the HIV surveillance data is actually, I misspoke for a second because we're not actually primarily doing interviews. It's really mostly derived from chart reviews. So we're able to ascertain from the chart whether they were on PrEP, but not whether they were aware of it before. So then looking at program data derived from providers, these are data from our public health detailing program. This is using the pharmaceutical company model of going directly to providers and presenting them with action kits about PrEP prescribing. And we do a very quick evaluation when we show up at the practices. So we do ascertain whether providers are aware of PrEP and whether they're prescribing it, as well as a couple of other important evaluation questions. So that's really what we felt we had when we began our mapping. I'm happy to report that we have a number of other things that are cooking that we hope to be able, other data sources we hope to be able to use in the future. One of them is that our community health survey, which is a citywide survey very similar to the BRFSS survey, will include this year a question on PrEP. So that is another source of data that will be aware to us. At this time, we only know that they're going to ask this question once, but we will certainly be rallying to get that question asked in the future, so we'll be able to look at time trends there. Next, we are also planning to conduct analyses of Medicaid data, and the state has already done some of that work, and that's what I'll be presenting shortly. And then all the way moving over into the bottom right of this grid, we have data from a number of different new programs, or we will soon have data from a number of different programs. One, we have new programs in our STD clinics to provide PrEP, and that, importantly for those who are familiar with it, this includes our CDC 15-1506 PrEP demonstration project funding. That's all mixed up in there. We have a new PrEP network, and this is a clinical network of providers that will be also similarly providing PrEP services and helping patients navigate to PrEP. We have an adolescent PrEP program, again, very similar to the PrEP network above. And then finally, we have Brooklyn-focused navigation programs that will be linking patients both to PrEP and care, and this is funded through CDC's PS 15-1509. Again, for those who are familiar with it, these are another one of the new CDC PrEP demonstration projects. So hopefully I've given you a sense of what all of the different data sources are, and now we'll be focusing in on the Medicaid analyses and the some PCIP data, some electronic medical record data that actually I did not even include on this. Oh yeah, it is that those are there too as well. Whoops. Okay, so now moving along to the Medicaid data, and first I'll walk you through a PrEP analysis that was actually done by our colleagues at the New York State Health Department. So you can see this was published in the CDC's MMWR. This is going back to the end of 2015. And in this project, they analyzed prescription data from the New York State Medicaid program that's housed in the Medicaid data warehouse. And they included data from July 2012 through June 2015 in this analysis. And in order to do so, they developed an algorithm using prescription and diagnosis codes to identify continuous use of Truvada for greater than 30 days. That's basically how they defined PrEP use for the purposes of this analysis. And they, of course, had to exclude any use that appeared to be PEP and any use that appeared to be associated with HIV treatment or as well hepatitis B treatment. So their findings were really very exciting. They found that prescriptions billed for Truvada as PrEP increased more than fourfold over the 3-year period of the analysis. So from 259 in 2012-2013 to 1,330 in 2014-2015. And then through June 30th of 2015, over 1,700 Medicaid recipients appeared to have received PrEP prescriptions. And the recipients who are filling PrEP prescriptions were predominantly male, under age 50. They did appear to be white, non-Hispanic race, and they appeared to be primarily residing in New York City. Recall that this is a whole statewide analysis, but predominantly they were in New York City. So importantly, though, these data have some limitations, including that there does appear to be poor compliance with reporting of race ethnicity. It does look like we really, from these data, we don't have an indication of the risk for HIV infection, so we don't know whether these individuals were primarily men who have sex with men. And patients were included if they filled even just one PrEP prescription. So we don't have there's no measure here of whether they were adherent to daily oral PrEP or even accessed it on more than one occasion. However, we do feel that there's incredible overall utility here. It helps us to identify the socio-demographic characteristics of PrEP users, so by the type of Medicaid, sex, age, region, race, ethnicity, and this allows us to better understand disparities so they can be addressed. And then as well, the overall utility is to track the impact of our activities across the city and state to support PrEP implementation overall. So now I'd like to tell you about some planned work in New York City around Medicaid data. So we plan to analyze claims data using our Salient, which is a data warehouse containing New York State Medicaid data on New York State Medicaid beneficiaries, and we'll do this just for those residents of New York City. So Salient contains administrative billing data such as hospital admissions and discharge dates, diagnosis and procedure codes, as well as prescriptions filled. And we actually plan to conduct a 3-way match, which is Salient with 2 other sources of HIV-related data for New York City. So HIV surveillance, and then a service provision database for all contracted programs, which we call eShare. And this match will really provide us with a more complete picture of prevention care and treatment utilization outside of our own service provision, and it will really increase our capacity to work across the system, especially with our colleagues in Ryan White, who work in the Ryan White system to address the payment of last resort requirement. But specifically, we think the benefit for care will be that it'll enable us to link prescription data with laboratory data for being able to assess engagement in care and care outcomes. And then for us in prevention, most importantly, it will exclude patients with an HIV diagnosis to ensure that we're really just looking at Truvada prescriptions for the purposes of PrEP. So for example, we'll be able to estimate PrEP prescriptions filled overall, again, ensuring that we aren't mixing up any people living with HIV there. We'll be able to measure associations with socio-demographic factors and kind of trends over time. And then we're interested also in assessing the feasibility of outcome monitoring. So like, can we look at incident STI diagnoses among PrEP users? So more to come on that. We have done some of the initial matching, but the analyses are forthcoming. So finally, I'd like to talk to you about a special project to look at electronic health record data, and this is called the Primary Care Information Project, and this is our PrEP-specific analysis within the Primary Care Information Project. So the project was to conduct an analysis of data from something called the Hub. The Hub is the Hub Population Health System, and it's data from primary care practices around New York City. They're real practices, and we were able to pull the data in aggregate from them. It's really, the data set includes hundreds of ambulatory care practices around the city. So this really enables us to have a citywide reach in terms of being able to analyze PrEP uptake. And the coverage is really phenomenal. So just in the analysis I'm going to present to you, we included over 5.6 million patient visits. For the most part, these data are just about practice level data. We don't have a lot of data on the individual demographics of these patients. So for this analysis, we queried the quote unquote hub records from July 2012 to December 2014. And we applied an algorithm to identify PrEP prescribing, similar to what others have used, really importantly trying to eliminate anyone who might have gotten Truvada for PEP or treatment or hepatitis B. And our outcome is PrEP prescription rates. So we calculate them by number of PrEP prescriptions per 100,000 patients seen in the practice. And I'm not presenting these data to you, but we can also drill down to the borough and neighborhood. I'll show you a little bit of that on the next slide. So these are the data for trend and rate of PrEP prescriptions. So it's, again, on the x-axis we have the quarter and year, and on the y-axis are the PrEP prescription per 100,000 patients seen at these ambulatory care practices. This analysis includes 538 ambulatory care practices, and again, we're looking at 2012 to 2014 data. And you can see the green line here is all of New York City. The red line is most of the rest of New York City, and the blue line is data from one specific neighborhood, which includes Chelsea and the Village, or West Village in New York City. And this is a neighborhood that has long been an enclave for gay men, bisexual men, and other men who have sex with men. So importantly, we are seeing that the prescribing is mostly happening in those neighborhoods, although you can see from the green line that there also has been a dramatic increase in PrEP prescribing in all of New York City as well. These data were presented previously by my colleague Zoe Edelstein and Paul Salcuni at a couple of different conferences over the past year or so. So next I'll move on to really a geographic distribution of the rate of PrEP prescriptions. And again, you can see that there is, as I described on the previous slide, a very much a hotspot for PrEP prescribing in the Chelsea, Clinton, downtown Manhattan neighborhoods, and then much less in the way of PrEP prescribing outside of those areas. If I had more time, I would also show this next to a slide of where our new diagnoses are occurring, and there is good overlap in Manhattan, but then some of the outer boroughs also have a high burden of new diagnoses and do not have as many providers prescribing PrEP. Really importantly, though, these are practice level data, so I'm not talking here about where the people live who are getting the PrEP, but this is a little bit of a signal for us that there is some sense of possible disparities in accessing PrEP in New York City. So finally, I wanted to highlight a couple of findings from an analysis done, again, by Paul Salcuni and Zoe Edelstein. This is an analysis of practice-level factors associated with PrEP prescribing. So again, we don't have the individual sociodemographics, but we do know that it looked like the PrEP prescriptions were primarily coming from community health centers versus independent practices, practices that saw a higher percentage of patients who are male or assigned to an infectious disease specialist were more likely to be prescribing PrEP, and then practices that saw a lower percentage of patients who are living in high poverty neighborhoods and marginally those who are Black and Hispanic, again, were associated with PrEP prescribing. So just some of the interesting findings that were from this particular analysis. So what are the limitations of these data? Well, anytime you're looking at electronic medical record data and trying to pull out prescription data from there, that's inherently limited. I mean, going forward with mandatory e-prescribing in New York State as of April of this year, hopefully we will see that less, but I think it's possible for a medication to show up in the EMR without actually being ever prescribed or taken. These data are all practice level and cross-sectional, so patients get duplicated kind of within each quarter, but not across time or practices. And then these practices are really, even though it's many practices, so over 500, it's really not representative of all ambulatory care practices in New York City. These practices are primarily small independent practices in community health centers, way fewer hospital-based practices. And then the time trends and associations that I just described to you may not be generalizable either. But we feel the overall utility, very similar to the Medicaid data, like it helps us identify trends in PrEP use and understand disparities in prescribing and really track the impact of our activities to support PrEP implementation overall. So just some parting thoughts. I've spent some time telling you all about all these analyses, but I didn't tell you about the sweat and the tears of analyzing these large data sets. It's really time consuming. We have an amazing team doing this work. But it is really time consuming and resource intensive. So even though the outcome is phenomenal, being able to talk very broadly about PrEP implementation in the jurisdiction, it's not without its major drawback in that sense. And then each source, as I hopefully indicated to you just from the two I talked about here, really has its limitations. So it's important to collaborate across teams and really triangulate data to be able to truly track what's happening. So thank you very much for the opportunity to, to present, and here are a large number of colleagues, both at the City Health Department, the State Health Department, and SUNY Buffalo, who all were involved in some of the analyses here. So thanks very much for the opportunity.
So we are going to kind of share today a PrEP assessment using APCD. So this is a very beginning stages assessment, just to walk you through. So just kind of an overview of what APCD is. So it stands for All Payer Claims Database, or data. We'll use that interchangeably. The people reporting to APCD are Medicaid, not Medicare, and then all companies insuring 2,500 people or more. And the claims being reported to this database include medical claims, pharmacy claims, lab claims, some dental, and now they're also seeing some vision claims. Some estimates are reporting that it's the reporting is as high as 80%. A recent estimate with the Utah Cancer Registry estimated reporting at 70% completeness. Later on, I'll walk you through, kind of show you what we found to be accurate with HIV and Truvada more particularly. So the first step in trying to access this data was creating a data sharing agreement. So this was an internal data use agreement. I'll walk you through some of the points we had to include in this. So the general purpose for access and the use with the data, the total duration of the access that we'd be using the data, how the data would be used, the type and source of data requested, the location or system where the data will be stored and used, and then we had to define specific identifiable data that we would have, and then agree to the data stipulations by the APCD. So kind of why we chose to do APCD. So we particularly kind of worked a little backwards. So our initial intention was to identify reporting gaps for our HIV surveillance data. And the two particular things we were looking at initially were individuals that were diagnosed, receiving HIV medical care that had not been reported to the surveillance program, as well as individuals who had incorrectly identified as out of care that were actually in care. So that was the initial starting point, and that kind of filtered down to a unique way to potentially look at PrEP prescriptions. Specific APCD codes, we obtained the data set using ICD-9 codes to identify HIV care visits, CPT codes to look at HIV viral load and genotype lab tests, NDC codes to look at antiretroviral medications used in HIV treatment. And we were only allowed to access the data that fell into these categories. So after the data was given to us and the data agreement was agreed upon and signed off, we matched the APCD data with our surveillance data through EHARS. In total, there were 1,693 matches. So 1,601 of those were done through a system called linking, and then 91 were manually matched, which is pretty intensive work. And then of those, 994 individuals did not match to our surveillance data, and they fell into those 5 categories. So perinatal events, so babies born to HIV positive mothers, out-of-state residents, individuals with a single claim that fell into our codes, individuals with 2 claims, and those with multiple claims. And so for looking at the PrEP evaluation, specifically, we looked at the 3, so the single, 2, and multiple claims. So for the single claims, all the single claims fell into several categories. Again, to get to the potential PrEP prescriptions, we looked at single ARV claims, so a single claim for Truvada that did not have a corresponding viral load. And of those, we had 36 Truvada claims. And then of the 2 claims, we had individuals who had 2 ARV claims with no viral load. There were 14 Truvada claims. And I apologize, so these are all mutually exclusive of each other. And of the multiple claims with no viral load and coinciding with it, there were 73 Truvada claims. So in all, we had 123 claims indicative of PrEP prescriptions. So some of the limitations with this data, so it's a very straightforward and simple, like I said, we're in the initial stages of this. So pretty straightforward evaluation, just looking at individuals who had a claim that was kind of out of the norm or not as we would see in regular HIV treatment regimens. So some of the limitations that we found with this particularly is that our data was 60% complete when matching with surveillance data. And then we're assuming that a single Truvada prescription without a viral load is for PrEP. But one thing to note with that is there were other claims for a single ARV. However, those were like 1 claims versus the numbers we saw with Truvada. And then another limitation with this data is we cannot use the information to contact providers at this point. So if we were to create a provider list, again, since Utah is in its early stages of PrEP, we're still working on education and seeing what providers have the capacity to provide PrEP prescriptions. So this potentially data could not be used to contact those providers to identify who is. Our kind of evaluation plan going forward to obviously continue with the APCD data to refine it. And we did a really straightforward, simple way. And again, we kind of fell into this assessment, but refine it, see if we can maybe make it a little more fine-tuned, and then identify who is actually prescribing PrEP in order to kind of roll out our other campaigns. In terms of other evaluations we have, kind of more simple, but we plan over the next year to do provider assessments, local health department assessments, and community assessments to just identify overall knowledge of PrEP, ability and capacity to prescribe PrEP, willingness to take PrEP, and just assess overall awareness of PrEP. So those will be pretty simple, straightforward assessments. And our next steps are to roll out those assessments, as well as kind of continue working with the APCD gatekeepers. Again, APCD is not, we haven't used it often in Utah, so this was kind of exciting to have the opportunity to use this data, and they're equally as excited for us to use it, but it's still a work in progress to see how this data can be used going forward, and what we can and cannot do. And then also, since Utah, we don't have actually the capacity right now to provide PrEP prescriptions or insurance to provide, to purchase PrEP, to obtain PrEP prescriptions. Our campaigns will solely be education and awareness, and making sure providers have the capacity to take care of any interest that they have, and then hopefully to end with community events to kind of roll into that as well. So are there any questions? And sorry, this is last little slide. Christina Larson, who used to be with the Department of Health, who's currently with the Louisiana Department of Health, did the initial analysis on this, so a huge thank you to her.
Thank you. Thank you once again to both of our presenters. I think they're doing very, very innovative work, and we're very happy that they were able to share with us. One question we have for Dr. Myers is, are there key considerations that HIV programs take into account when looking to evaluate PrEP in the jurisdiction?
So evaluating how well implementation is going? Well, I guess the key thing is to be able to track some of the demographics that are of special interest related to PrEP. So, you know, we already know that there are health disparities I don't mean mine in particular, but like in general, the work on HIV care has shown that, you know, in particular, Black MSM have difficulties accessing care, that they, you know, tend to drop off the care continuum at different times because of kind of a lot of structural issues. So I think we have to be very, very aware that we don't let the same thing happen again with access to prevention. And so I think being able to, you know, evaluate how well all the specific vulnerable populations are doing in terms of being able to access PrEP is really important. So, you know, whether it's following just uptake of PrEP among that population, but being sure to include key covariates like race, ethnicity, and, you know, age as well, I think is critical.
Thank you. Thank you. Thank you. Moving forward, what are your main objectives for evaluation using health systems data?
Yeah, I think just starting with a good baseline to see if we do have an uptake, so refining this data, because as I said, there are a lot of limitations. And then I think we also want to rely on surveillance data a little more. Dr. Myers pointed out they're using a lot of different sources of data. Right now, this is the first thing that Utah has done. But we really do, particularly with our education campaign, we want a good baseline in order to compare it to towards the end.
Thank you, thank you, thank you. There's a question for Julie, saying you mentioned one of your key outcomes is PrEP awareness. How did you measure this?
Sure, I can share the specific language with you. It does vary a little bit, to be totally honest, across the different surveys that I've mentioned. You know, so between our sexual health survey, our NHBS, our MMP, but it's basically something to the effect of, did you know that there is a pill that you can take every day to prevent HIV? It's literally at that level. And so we have tracked this over time, and I didn't show you those data, but we presented on some of that at the National HIV Prevention Conference at the end of last year, and we have seen a really dramatic increase in the proportion of young men who have sex with men. When I say young, I mean like 18 to 40, and that's the population that we reach through our sexual health surveillance, and that the proportion of they're aware is increased really steadily over time. So even though, to a certain extent, I think a lot of us feel like, wow, we're immersed in this world. We kind of assume that most people are familiar with PrEP, but the answer is that we're still not getting 100% of people even just, at that basic level aware. And we're similarly, anecdotally hearing that there's kind of lingering confusion between what PrEP is versus what PEP, post-exposure prophylaxis, is. So that's another consideration. But I'd be happy to share the text that we've adopted on both on all of the survey instruments I mentioned. I'll mention, just since it's related, for use, we are asking, or we're looking at use in the past 6 months as a measure. We feel like every use probably isn't as important, because we kind of want a sense of, to a certain extent, current use, but maybe a little bit capturing some of the, going on and off PrEP that we suspect may also be happening, and perhaps appropriately so if people, are kind of going in and out of the quote unquote like seasons of risk.
Thank you. We have a question for Ahmer about the next steps for the program, given that it's still in its beginning stages. Would you explain the framework for your evaluation program?
Yeah, so right now, similar, so this kind of ties into Dr. Myers. So basically in terms of evaluation, we would like to have a baseline. I think that's still in the works in terms of measuring awareness and actual prescriptions. I think for the kind of provider assessments and community assessments, we hope to do quick little surveys. So in Utah, we have at the kind of most known testing sites, so Utah AIDS Foundation and some of our local health departments, each client comes in with paperwork that they have to fill out. So including surveys or just questionnaires in there, and then using that at a later time.
Thank you. Could you provide any general considerations for health departments trying to plan and budget the cost of acquiring and analyzing these data?
That is a good question, and to be frank, I'm not really sure that I can answer that. I think particularly the project I described to you with the electronic medical records, that was facilitated by the fact that the health department years ago, and I'm talking like about 10 years ago or more, got a large grant to support electronic medical record distribution to practices in kind of resource-limited neighborhoods. And so we're basically tunneling into electronic medical records that have similarities. And I don't know that without that detail, it would be very easy to do the kind of aggregate analysis that I described. In terms of getting licenses to something like Salient, which is this commercial product, those are somewhat expensive, but I don't know the cost offhand, so I really apologize. I can't really fully answer that question. I'd be happy to follow up with whoever's asking that offline.
Thank you. Another question from one of our participants. What is the source of your sexual and behavioral health data, and why does it only include un- or underinsured MSM and trans women? Is this from your ADAP provider network?
It's actually it's programs that we fund. We use our CDC funds to support these programs, so that the data are derived from clients who are participating in that program. So we ask them upon entry into the program if they're aware of PrEP, and then we ask them as well if they're using PrEP. And then as of July of last year, we also started offering PrEP through the program. So they've now become kind of another PrEP delivery program. But in the past, they were just providing other services like STI and HIV testing and TI treatment.
Thank you.
I'm happy to offline share more information about how those programs are structured. I guess you know, maybe something that was like a little bit of the lost in the presentation, you know, kind of the forest that I didn't explain through the trees, was that what I'm really trying to convey is that I think we all in our various jurisdictions can use a number of different data sources, like by thinking, you know, strategically about embedding questions about PrEP awareness and use into our existing programs. You know, particularly I think like having our partner services staff ask about that, I think is you know, there's like very minimal increased work and very minimal increased burden to the staff to just be able to collect those data, and then that becomes an ongoing source of data about how PrEP implementation is going in the jurisdiction. So that, you know, that asking our clients coming into all of our funded programs about PrEP, I think is an example of that. And the SBH, the sexual and behavioral health programs, are just another one of our programs into which we embedded questions about PrEP awareness and use.
Thank you. Thank you. Another question. Are you tracking how long people are staying on PrEP? In Miami, we've noticed many are not staying for longer than 3 months.
You know, that is something that we're interested in. I'm trying to think if we have a specific question. I'm looking over at another colleague, whether she knows whether we have any questions about that.
Oh, sorry, Dr. Myers, just to jump in. So this is something we're trying to do as well, or kind of map out how we would do this. And with the ABCD, it works well because there are claims. You can follow a person and as well as date as prescription. So this is something we have just been talking about in the past weeks, is using the ABCD to see the duration of the claims, how far, if it is consistent with a PrEP regimen, and then just tracking individuals that way, because you can see breaks down to like number of claims.
Yeah, thanks for jumping in. I think basically it's the same for us. So like the Medicaid data through Salient, and then our data through the electronic medical record data in aggregate, like we will start to be able to see that going forward. As you hopefully got the sense of through that the graph that I showed you, like we're in the like explosive growth phase of PrEP. So I think most people like hadn't even had a chance to discontinue by the time we were doing that analysis. So that'll be kind of something to follow going forward. But also in our newly funded PrEP programs, like, you know, providing PrEP in our STD clinics, providing PrEP through the other programs that I mentioned, like we will obviously be tracking, you know, some sense of retention and adherence through those programs.
Another question for both presenters. How often are you doing data pulls for these analyses? And as part of that, are you doing these analyses on an ongoing basis?
So we're actually still establishing that. This, I think I pointed out, was from 2014 data. This is something we definitely want to do by the end of this year, particularly at the start of our PrEP education program. And then it will be done probably at least on an annual basis, hopefully. So that's the goal right now.
Hi, this is Julie. Yeah, I mean, I think for the most part, it's realistically only about once a year for the for like a Salient analysis, that, you know, Medicaid analysis, or the electronic medical record analysis. It is such a colossal effort to do that data pull that, and we're working with colleagues who have a number of other projects on their plate. So that's basically what it's turned into. I will say for our sexual health survey, a sexual health surveillance that I mentioned at the beginning, I didn't show you any data from that, but through that survey, we do twice a year surveys online. We only do once a year in person, but we realized it wasn't that much additional work to do it twice a year, and so that gives us kind of an additional data point every year. But I think, you know, even so, we kind of do the in-person annually.
Thank you. I have a question about using aggregate versus individual level data. I was wondering if you could talk about any opportunities for re-engagement in PrEP services, for example.
Let me make sure I understand your point, like using like something like individual level data to help people to re-engage in PrEP?
Yeah, is that a possibility at all, or no?
I think the tricky thing is like what can any one provider do outside of a given like funded PrEP program, given that there's no like disease state? You know, I think a lot of I assume you're kind of thinking of something parallel to like the data to care concept, and that's, I think the foundation of that is that those individuals are already HIV infected, and so there's like a lot of impetus to go out and find them. I'm not sure that there would be as much impetus for people who are who are negative. However, I feel like a lot of our new PrEP programs, and I didn't get into this, but like are kind of based on the concept of patient navigation. So helping people to navigate through the very difficult medical system, you know, at times. And so kind of inherent in that will be an opportunity to reach out to people who may appear to have fallen out of PrEP care. So I'm not sure how the health systems data can help with that. To me, it seems more like, you know, it has to be individual level data, and it really has to even be like data from within a specific program. The patient has to already be involved, patient or client has to be already like enrolled or involved in a specific program. That's how I'm seeing it.
Thank you. Are there any closing comments that you want to share with our audience?
No, just thanks for the opportunity to present, and sorry there are a couple that I wasn't able to field, but if people want to email me directly, I'm happy to engage offline. And again, thanks for the opportunity.
Thank you both for your presentations, and thank you everyone for joining us today. Our next webinar in the series is going to be on August 17th, focusing on models to deliver PrEP in community health centers, and again, looking at the financing components of that. Thanks everyone. Have a good day.
Thanks.